If I puff, then only I can concentrate. Is that an excuse that they're giving to themselves?
It's not an excuse. Now I'll tell you, when they're very, very tensed, when they're very, very stressed out, they take a smoke. This is poor coping actually. Now the body gets you some relaxation at that moment. It is momentary relief, but long term the body wants more cigarette. The anxiety increases, and the reinforcement in terms of the cigarette or the tobacco or the alcohol requirement increases. So they have now got into a faulty coping mechanism, which temporarily relaxes them from the anxiety, but in a permanent way it damages the whole system. But the body is constantly wanting or craving for more and more of the substance.
मैं एक इतने इन डेप्थ गया हुआ इतना खराब केस हूँ बाइपोलर डिसऑर्डर का और एक मेंटल पेशेंट हूँ मैं आज भी.
Bipolar is a disease where sometimes somebody has depression and sometimes somebody has mania. Again, mania is something which is very, very underplayed. Mania is again a mood disorder where somebody feels excessively happy. His mood is absolutely on the top. He has increased self-esteem. He feels that he's on top of the world. He's a politician. He has crores of rupees. He dresses well. He wears good dresses. He spends excessively. He has 1,000 rupees. He will donate 1 lakh rupees. He will talk big talks. He'll be having dangerous, reckless. He'll be driving a vehicle at 150 kilometers. At the lower pole is the depression, and at the higher pole there is mania.
Thank you, Dr. Amrit, for taking out time and being the part of Saar Holistic Wellness podcast. And we want to introduce Dr. Amrit Pattojoshi as a neuropsychiatrist and head of Psychiatry Department in High Tech College and Hospitals in Bhubaneshwar. Welcome, sir, and thank you so much for taking out time.
Thank you for inviting me to your podcast.
Thank you, sir. So my first question is, how do people know if they are addicted to alcohol or if it is a daily affair for them?
Yes, yeah. Like if you look at addiction, we talk it as addiction basically stigmatizes. So we call it as dependence.
Okay.
So if you look at the terminology, addiction means something, it's a little stigmatizing. So we talk about dependence. So there are two types of dependence basically in current terminology. We talk about dependence in terms of substances. It might be cigarettes, it might be nicotine in the form of chewing gum, chewing pan, pudia, it might be alcohol, it might be cannabis in the form of bhang, ganja or hashish or charas, whatever you tell. It might be brown sugar, it might be sleeping pills, it might be the synthetic things like cannabis. We have synthetic cannabinoids, we have MDMA, we have ecstasy, we have cocaine. As you get more money, your dependency it becomes more expensive. And also we have the behavioral dependencies or addictions, what you speak about. And it encompasses gambling. We see a lot of people gambling, not able to leave gambling. Compulsive buying. We see a lot of people, watching porn. We see a lot of people on the internet playing video games. There's a lot of people, the social media. So these are the behavioral addictions. So these are two sets of dependencies or addictions which we seek in current practice. So when do we know that? And if you look at the criteria, like you're asking me, what are the criteria? When does somebody feel like look at me? I might be using my mobile for a long period of time.
Yeah.
But if you take away my mobile, I'm absolutely okay with it.
Okay.
I don't feel jittery. What happens how does basically, if you look at how dependency starts and how it progresses, then you'll be able to understand.
Yes.
Like suppose let us look at alcohol.
Yes.
Suppose you have somebody who comes that my son or daughter is taking a lot of alcohol and not able to control. Now, how do you decide? Now we see how does it start. Any substance starts with a less toxic or less dangerous thing. Like it starts with a simple cigarette.
Okay.
You're standing with your friends, a lot of your friends, you want to be accepted in your group. You are standing with 5 people, 3 are smoking, and अरे पी ले यार अमृत, क्या एक फूंक से क्या हो जाता है? Just and you just try to experiment, and then you get that rush. You feel better. Some people take it. Come on, I don't like this. I'm comfortable among all of you, but I don't want to take.
Right.
So and then once one puff goes to 5 puffs, 5 puffs go to a cigarette. One cigarette a day goes to 3 cigarettes a day. Then it becomes 10 cigarettes. Then your whole brain is focused on the cigarette. Now you know that initially you would get high or you would feel good with a cigarette a day. Now you need 8 to 10 cigarettes a day. Means Your body now has tolerated one cigarette and wants more.
Okay.
You know that this cigarette is causing you harm. You read everywhere. You take out the packet, you see the skull, you see lungs being destroyed. You read cigarette is injurious to health. You know, it's creating a lot of issues in terms of the psychological health. You are reading, but after 45 minutes, you need to come out to have a smoke. You're at home, you're in a function, you need to get out because your body now shows withdrawal symptoms. Either the body wants it, there is irritation, there is something, or you crave, you want it desperately to take it. Otherwise, you're not feeling it. So you either have withdrawal symptoms, you have craving, you have tolerance. You know it's going to cause harm to you, but you're still taking the substance. It makes you tell lies. You come home, your mother is telling you smelling. What did you take? You are a student. You get a pocket money of 2,000 rupees or 1,500 rupees per month, and that you need to take care of a lot of things. But now you started stealing certain money because every day you need 300 rupees for your pack of cigarettes.
Yes.
You're doing some reckless behaviors. You are, somewhere you know that you are not in control anymore. You can't live without that thing. That makes you feel that now I am dependent or I am an addict. You get the point. The whole concept is this is how it grows. And at one point, you can't live without. You feel you can't live out. The moment you try to curtail it, the moment you try to stop it, you have other kinds of symptoms. You are irritable, you are jittery, you are anxious, you're not able to sleep, your hands keep trembling, you are not able to go to the washroom, your appetite goes for a toss. So a lot of other symptoms come. That is how you decide that. And you're not focused on what you're doing, not focused on your studies, you're not focused on your work, because every 45 minutes, 1 hour or 1.5 hours, you need to get out to have a smoke or maybe have a tablet. You're taking zolpidem, you're taking a little bit of stuff. So your whole life, your
Dr.
working
Amrit, I
styles.
meet a lot of people who say ki if I will take a smoke, if I'll puff, then only I can concentrate. And is that an excuse that they're giving to themselves?
No, it's not an excuse. Now I tell you, the smoke. Now, if we talk about cigarette, we talk about a benzodiazepine, we talk about alcohol. Somewhat it is an anxiolytic. Now, many of the people who are a little anxious, little depressed, they take a little bit of when they're very, very tensed, when they're very, very stressed out,
Yeah.
they take a smoke. This is poor coping actually.
Yeah.
Now the body gets you some relaxation at that moment.
Okay.
It is momentary relief, but long term the body wants more cigarette. The anxiety increases.
Okay.
And the reinforcement in terms of the cigarette or the tobacco or the alcohol requirement increases. So they have now got into a faulty coping mechanism, which temporarily relaxes them from the anxiety, but in a permanent way, it damages the whole system. But the body is constantly wanting or craving for more and more of the substance. And then your whole focus is on that, not on other things in your life anymore.
Right, right. I want to quote one example from my family friends only. So we have this friend who is constantly taking alcohol, and we all are trying and struggling to put him on a rehab. But he says, no, I'm fine. I will not lie again. I will not do this again. And he's just not ready to go to rehab. How should we help that person? We are all ready to help him, but he is in complete denial all the times.
Rehab is not the only solution to somebody who's on substance. Now, we need to understand why he's taking substance. Substance is not a character flaw or a cycle. It's a disease. Now, you have to put it on a disease model.
Yeah.
Where the disease model talks about, the person wants to live substance, but he's not able to live substance.
Yeah.
Now, we have to talk about the medical.
Yeah.
Is it because of the craving he's taking it? Is it because of the strong withdrawal he's taking it? If it is a strong withdrawal, we need to give medication that take care of the withdrawal symptoms. If there is a strong urge to take the substance, which we call as craving, then we need to give an anti-craving agent. If the other things, if the sleep is impaired, if he's becoming very anxious, jittery, we need to pharmacologically help him.
Yeah.
Help him. Because anybody who takes substance, and alcohol is one of the commonest things where there is a lot of denial.
Yes.
They don't understand the magnitude of the problem. They tell that I'm just drinking, I'm in control. I take one peg in a couple of days, or I take thrice a week, or I take twice a week. Anybody who tells that I take twice a week generally is taking every day. So there's a lot of denial, and as long as you deny there is a problem, you can't look at the solution to it.
Yes.
So putting them in rehab is not the solution, but bring him to a doctor who can talk to him, who can give him something that will relieve his psychological symptoms, physical symptoms which occur when he tries to leave the substance. That's how we show him that there is improvement. Please be with us. We will get better and better as the day progresses. And if we understand that he's having physical issues in terms of a pancreatitis, in case of a hepatitis, he's having blackouts, he's having, withdrawal fits, and he's not listening to us, it's his physical health is in danger, his mental health is in danger, we need to put him in rehab.
Okay. So it's a step-by-step process, just not that you bring the person and put him in a rehab. Consult a psychiatrist, consult a doctor, put him on a medicines, and then follow the process as prescribed.
And for example, I tell you, if the husband and wife are not getting along well, there's a lot of stress at home, and you put the male in the rehab, you give it, and then he goes back to the same environment. So a lot of times we give family therapy, a lot of times couple therapy is important. So we need to understand the magnitude of the problem, where the origin of the problem starts. I'm not telling that somebody who's taking alcohol is doing the right things. There is poor coping skills. There is a malfunctional system which is working. But then as long as we don't correct the things which makes him do the things, be it lack of sleep, be it anxiety, be it a fight at home, anything, be it the wife is cheating on him or the daughter is going out somewhere which he cannot control. As long as we don't try to improve on these things, it's almost a futile exercise.
Okay, got it. Very amazing answers, Dr. Amit. Till now, I was also not aware this all happens and there is a proper circle behind it. Thank you for addressing it. And I want to ask you one more question around addiction. Can addiction be genetic or hereditary, or it is just developed by the person, like in the circumstances?
Like, if you look at, there is no one reason why somebody takes substance or somebody goes into dependency. But one of the commonest things which you find is that if there is a first degree relative or a parent who is taking substance, there's 40 to 60% chance that the person will, if I have a father or a mother who's taking substance, I have an uncle, I have a grandfather, any immediate family who takes substance, there's a strong genetic loading of substance.
Okay.
It's one of the reasons. But there's any disorder in psychiatry, we call it a biopsychosocial model. Biology is the hereditary or the genetics which we are born with. We can't do anything about it. Maybe after 10 years, 20 years, we'll have genetic engineering, we'll have a lot of things happening. But till then, we have to live with the genes which we are born with. Then is the sociology. How somebody is going to. Somebody is in a broken family. Somebody has a home where the mother is going out somewhere. The father is coming home drunk. There's a traumatic life events. They are prone to have more conduct issues, behavioral issues, and they might go into substance much. Peer pressure is an important issue when it is substance. Then modeling, whom we look at. Suppose I model somebody who drinks, I'll try to drink. I'm in a college where I look at a senior who drinks, who smokes. I think this is how you need to be. And this is how I'll be recognized. I have low self-esteem. I need to prove to others that I am as manly or as womanly as anybody around me. Like people put their social media, a lot of people put cigarette, with alcohol, with, I directly tell them, please don't post such pictures, but people take offense and block me. That's okay with me. I'll do what I have to do. So, and a lot of other issues also. Mental health issues is one of the major reasons why people go into substance. The people with schizophrenia, I see a lot of them taking cannabis. There is a self-medication hypothesis where people who take substance have their anxiety reduced, have their hallucinations maybe. So if people with depression, people with anxiety, people with a lot of personality issues, people with schizophrenia, I see them using a lot of substance. So mental health issues is a major issue why people take. And then stress. If people have, my psychology is I have stress. I learn how to cope it. I handle it. I face it. I know that this is temporary. But somebody with a substance, who has poor coping skills, somebody will tell him, "Do peg pee le, yaar, theek lagega." Pop up 4 pills, you will feel better. Popping up pills under the guidance of a psychiatrist who takes him out is good enough. But again, be careful to people who abuse things. Like a lot of people ask me for stimulant. A lot of people, you give a prescription, they'll take 10 times the drugs from different counters. So you need to be very careful about what you're giving, whom you're giving, how long you're giving. So anybody who has a propensity to, genetically or psychologically who is prone to, certain personality types will go into addiction much more. The cluster B people will go into, So it's a whole interaction of a lot of situations, circumstances, genes, what the early events in life has been, and that maybe leads to dependency or addiction, as you call it.
So, sir, I want to know, Dr. Amrit, what are the three top mental health disorders are most common in adults?
Common in terms of the prevalence, common in terms of who come to us. If we talk about the mostly common, I will talk about anxiety, which is the commonest
Yes,
thing
yes,
that is affecting our generation
yes.
today. Next is depression or mood disorder, which we see. And the third most common is substance abuse disorders or addictions, which you call about that substance dependence, anxiety, and depression. These are the three commonest things which we see in mental health practice.
Dr. Amrit, I want to know more about, everybody talks about very casually and normally about anxiety and depression. These days, I'm depressed and I have anxiety. But mood disorder is something picking up. So, can you please throw some light on what is mood disorder and what are the early symptoms of recognizing mood disorder?
Like when we talk about mood disorder, there are two types of mood disorder which we generally see in a clinical practice. One is depression, which is a unipolar depression, and another is a bipolar depression, bipolar mania. So I'll be talking about three different entities today. So when you talk about depression, what is a mood disorder actually? Mood is how we perceive something. Like overall, I'll ask you, how are you feeling today? You tell, I'm feeling happy. I'm feeling sad. These are all temporary things. This is the spectrum. Sometimes we're a little happy, sometimes a little more sad. Most of the times we're stable. Over a period of time, as you grow up, as you mature, you know how to be stable. You don't get too much up or too much down. You know that yes, up down chalte rehta hai, but then my mood state is a stable mood state. Sometimes you will be happy, sometimes you'll be sad. That's how life is. But if you are persistently remaining sad, and there's a time period when we look at if somebody is sad for more than 2 weeks. So what are the symptoms of the sadness that makes you make it a clinical diagnosis of depression? One is low mood. You feel sad, you feel crying, or you feel little down. Then loss of interest in pleasurable activities. Like suppose you are very, very interested in doing podcast, you are very, very interested in reading up, you are very, very interested in gardening, somebody is interested in sports, somebody is interested in going out, clubbing, pubbing, whatever you tell. And suddenly we see that this man or this woman is, or any gender it might be, they're not doing what they used to like before, maybe reading a book. I see this man who was always watching a game of soccer, every match in the Champions League, every match in the Indian Soccer League. He's not watching. Somebody who was watching IPL is sitting in his room, isolated, not doing what. So there's a loss of interest in pleasurable activity. So things that used to make me happy, now I'm not doing those things. So there is a low mood, there is loss of interest in pleasurabilities, and there is I'm not interacting with people. My interactions with people is less. I'm not, I'm always having the feeling that I did not do well in life. I feel that I am worthless. I'm of no use. I have no help. Nobody is there to help me. That's okay. But once you start feeling that I am worthless, I am helpless, but I have hope. The moment you start losing hope, the future also is dark, is gloomy. There's no hope. There's nothing that makes me feel that I should live. Okay, I'm not good anymore. I did not click my entrances. My parents are angry on me. My girlfriend has ditched me because I did not get the entrance. She moved around with somebody who got the entrance. That's fine. But I know that tomorrow I'll get the entrance. I will click it. My parents will start behaving better with me. And I'll have to. But once I think that no, I'm not able, I will never be able to click it. I'm no good. Everybody has ditched me. It's better I die. That is where somebody feels suicidal. And those are the hope is what we live with. And the moment somebody loses hope, so our duty is always to give people hope. Whatever hopeless the situation may be, we have to give hope to. As a clinician, people tell me, how can you lie so blatantly? I told, if I give them hope, they fight. And if they fight, they'll win it. I'm the man who will give them hope. Because for me, the victory point is not too huge. It's just one step if somebody takes, he starts fighting and then he gets back to sleep. Then there is loss of sleep. There's loss of appetite. Sexually also people does not feel good enough to indulge in all those things. So the biological functions are important. So all in all, we feel somebody who is crying, who is not happy, you're not interacting with people, who is wearing dark, gloomy clothes, whose speech has reduced, it has become slow. You can easily know that somebody is depressed. His eyes are not maintained, he'll be looking down, little dark clothes, not being interacting with people. feeling that he is guilty for whatever bad is happening around him. Hmm. All in all, he feels miserable. He feels that he is no good. That is depression, actually.
That's
Again,
so,
depression is of two types. The mood, you're talking about mood, I'll talk about the other aspect.
yeah.
So, one is a unipolar depression. Then there is a bipolar depression. A bipolar is a disease where sometimes somebody has depression and sometimes somebody has mania. Again, mania is something which is very, very underplayed.
Okay.
Mania is again a mood disorder where somebody feels excessively happy.
Mm.
His mood is absolutely on the top. Either it is on the top or is irritable. He has increased self-esteem. He feels that he's on top of the world. He's a politician. He has crores of rupees. He dresses well. He wears good dresses. He spends excessively. He has 1,000 rupees. He will donate 1 lakh rupees. He will talk big talks. He will, he'll be having dangerous, reckless. He'll be driving a vehicle at 150 kilometers. He feels that no harm will come to him. He will not sleep, even though he'll not be sleeping, he'll be feeling very energetic, very fresh. You feel a manic, you will feel something else. He'll tell that I'm the chief minister of the country, I'm the prime minister of the country. I have
Okay.
1,000 crore rupees. He'll become hyper religious. He'll be donating more. He'll be spending more. He'll be not sleeping, not eating, and then also he'll be very energetic. We call it as mania. So the one end is at the lower pole is the depression, and at the higher pole there is mania.
So bipolar depression is when you have two sets of emotions, like one where you're too high and one when you're too low.
They come at different times. This year there might be a manic episode where somebody is feeling high, and maybe after 2 years there will be episode where somebody is. So any depression associated with mania is a bipolar depression because the treatments are absolutely different.
Yes.
If somebody is having only depression, it's a unipolar depression. If somebody is having a depression with a past history of mania, it's a bipolar depression. So both the treatments are absolutely different.
But the signs are mostly visible if
Yes,
it is.
signs of depression are same in both the poles. Only in one there are signs of a manic episode in the past.
So what are the early signs of autism that parents should recognize at early stage intervention?
If you look at autism, the early signs of autism, we look at number one is the interactions. The eye-to-eye contact will not be there. The verbal communications are absolutely impaired. Even the non-verbal communications are impaired. There is no reciprocity in the emotions. Like the mother is emoting, there's warmth, there is love. There's no back emotional flow in terms of what the child is reciprocating. The child has a limited set of activities which are very repetitive sometimes. They are little, you get the point. Their interaction, their actions are very, very limited in a certain sphere. They're very intense, but they are very limited. So there is lack of reciprocity in terms of the emotions, a lack of communications in terms of how they communicate. There is a restricted pattern of behaviors and actions.
कोई एग्जाम्पल दे
They
सकते
are
हैं जैसे कोई रेपिटेटिव बिहेवियर या आई कांटेक्ट कुछ एग्जाम्पल?
देखो जैसे आप उनसे बात कर रहे हो मोस्ट ऑफ देम आंख ऐसे नीचे रहेगा जनरली व्हेन अ चाइल्ड इंटरेक्ट्स विद यू ही टॉक्स विद द आईज fixed to you or we talk with the eyes their eyes will they will be talking their eyes will be here but they will be interacting here. The child, when a mother is holding the child also feels what here the child has many of the children don't have much emotional reciprocity. Repetitive behaviors like they will be running around in circles and they have a fixed things. The chair should be here, the bed should be here, the lamp light will be here, the toy should be here. If you change it a little, they feel aggressive, they feel irritated, they cry, they might hit out. So somewhere they are a little different in a sense that many of the people cannot understand.
Yeah.
They're extremely sensitive children. They are, extremely sensitive. We thought where they can't, but they can't reciprocate actually. Even if some of the languages they use, like if the child's name is Amrit and you tell that Amrit, do you want water? They will tell Amrit wants water. They will never tell that there is a pronoun reversal we call it. They will not tell that I want water. They'll tell Amrit wants water. So there are certain things which and a lot of comorbidity with intellectual deficits, ADHD. They'll be having behavioral issues also. They'll be crying. What comes with the whole comorbidity spectrum in autistic disorders. There's a lot of comorbidity in terms of an autistic children.
So at what age, sir, the intervention can be done for autism, and at what age parents should consult a psychiatric, or parents should get the assessment done to understand if it is autistic or not?
By 2 to 3 years, you start to understand that there is some issue in the child.
माइलस्टोन डिले रहते हैं उसमें जिसमें वो
There'll be, वही तो बोल रहा है, intellectual deficits हो गया मतलब there'll be milestone, be it the cognitive milestones, the motoric movement, the speech is already, they'll have a lot of learning disorders, they'll have a lot of impulsivities, they'll have a lot of anger issues. So those are very, very common things like speech delay. We talk about speech delay, we talk about their intellect. They will be only interested in a limited number of things. Even if you give them a toy, they're more interested in rotating the key than the car moving around. If you give them a remote, they'll be interested only in the mechanism in which these switches are moving. They'll be going into the bits, not the whole picture.
Right.
So sometimes their level of memory is very, very high. They'll be memorizing a lot of things, a lot of mathematics. They do very good in mathematics, remembering tables, remembering dates, music. We call it just the seven skills, where they're very, very, highly high level of functioning in certain areas and almost limited functioning in a large number of areas. And
So-
interventions you need to intervene early, because if you intervene early, be it speech therapy, be it making pictures, reading out, things to them, making them sing with you, doing a lot of activities, be it sensory neural training, because they're very sensitive to what is changing around them, be it sound, be it light, be it substances. So sensory, integration is very, very important part of the therapy which we do for the children. We develop skills, we tell them how to, non-verbal communications we can improve, verbal communications we can improve. So if we get in early, we always get better results.
Right.
No,
One very important question: how do we recognize that my child is ADHD or my child is just naughty? Three logical symptoms that a mother can identify कि ये ADHD है कि naughty है कि ये ADHD है, क्योंकि आजकल बहुत casually यूज करते हैं हाइपर एक्टिव बच्चों के लिए.
a lot of people come to me with these things, that my child is hyperactive, ADHD. So now I just take a brief history. What is the child doing? How many people are there at home? What is the stimulus is getting? So now if there is nobody at home and the child is confined to a small apartment house where you are in the other room, I'm in the other room. If he shouts a little, it is, what happened when we lived in areas where we could run on the streets, where the field was just, the ground was just beyond our house. We used to just get out of house at 4 o'clock and come back 6:30. The mothers would not even think a second where my child is. But today we have come to a place where every minute, every second, your mother, your father is thinking about what is happening. So you always want to keep your child where you can see them, where you can see them fall, where you can see them. So what happens is, inside the house, if they're playing a video game, you are not free, so that the child cannot go and play with the other kids. So a little bit of, hyperactivity is there. The child will be a little disobedient. Sometimes the child will be a little moody. He'll throw a tantrum. That does not make a child a ADHD child. ADHD child means there is more persistence. If you look at the hyperactivity, if you look at the fidgetiness, if you look at the way they sit in the class, they sit to do homework, they're a little different. They're always on the go, on the rush. They're very impulsive. They want something, they want it now. Sometimes it happens that your child sometimes will be moody and want something. The child sometimes wants to show off in front of his friends that, yes, I don't care what my mother tells. Those are isolated events. There are temporary events and that get back to normal. But these child have issues that cause them impairment in the way they go to school, in the way they study, in the way they play with their kids around them. There are constant complaints. They'll be repeatedly leaving their tiffin in the school. They'll not never be finishing their homework. They'll forget their notebooks in class. Teachers will be complaining. Students will be complaining. So there is an impairment in their schoolwork, in the discipline, and it is persistent and it impairs all these activities. So then you understand that the child might be a hyperactive child or having attention deficit, and then that is the need for treatment or intervention.
But with intervention like occupational therapy, CBT, and other speech therapies, can ADHD be reversed or controlled?
We are managing a lot of ADHD. It's not just occupational therapy. I'm a psychiatrist. I will look at the overall management of a child. I don't want a hyperactive child to be hyperactive in school, to be stigmatized, to be isolated, to be thrown out of school because of certain behavioral issues. So we have stimulants which help children almost come back to normal, focus on their academics, focus on what they have to do, be disciplined, be accepted, not to be stigmatized, and the parents can live a better life. They can have a better quality of life. Secondary depression, secondary anxiety, secondary substance can be restricted. So if you look at the overall management of a child is always better because hyperactivity, because you can't be with the child. The child goes to school at 9 o'clock, 8 o'clock, comes back at 5 o'clock, 6 o'clock. So now we need to talk to the teachers about how to manage a ADHD child. Like suppose I tell to my students for 45 minutes, nobody will get up. But I'll tell to the ADHD child after 15 minutes, okay, come here, come here. Get me some water and come back. So he moves out, he comes back in. So after 15 minutes, there is some movement. I know that I've given homework to everybody or class work to everybody. I know the ADHD child can't focus. So I'll go and stand here and read it out, read the question to him. As a teacher, I always believe that equality lies in giving people different levels of intervention.
Right.
I cannot treat everybody thinking that everybody has the same skills. To somebody, I need to stand near him, or to somebody, I need to leave him and tell him that you can manage. That's how I do it. We need to focus on people who actually need our help, our support, and our guidance. Then only, I'll tell you a simple example of my daughter. She's never a ADHD child, but when her marks came in, I think KG2, I asked the teacher, they showed me that the student did not write. I told she is KG1, KG2. Did you take care of the fact that she was writing things? Did you stand near her? Did you see that she finishes it? No, I did not. I told them, why did you give my daughter less marks? You should get less marks, not my daughter. Because she's a small kid. It is your work to see that the children finish their work
Absolutely.
because she studied everything. After that, my wife never took me to a parent-teacher meeting. She told, you are not allowed anymore because. But I told that let us not try to undermine somebody because of my. So we need to take care of the ADHD children also. In the sports, we allow them to roam. We allow them to run. We allow, that's how we make them little tired so that they can focus on the other thing. But if you're confining them to closed spaces, not allowing them to take out, we have a lot of normal people who turn out to be ADHD. We think they're ADHD. If they're always on the mobile, if they're always on the video games, they're not doing a little bit of physical exercise. They're not running around. They're not punching. They're punching back. Those things are normal activities we need to do them.
So, Dr. Amrit, since you have also contributed a lot in LGBTQ community, so I want to know what are the top three mental health issues or, the things that they come up with to you for treatment on LGBTQ mental health things.
Like different segments have different areas. Like if you look at somebody who is a transgender, they have a lot of gender dysphoria in them, depression, personality issues, and substance abuse. They're very, very common in people with the trans community. But people with the same sex, the sexual orientation issues in terms of homosexuality, lesbianism, again, they have issues with coming out to the public that yes, they that is one very important issue. Again, anxiety, again, depression. A lot of people have suicidal thoughts, suicidal wishes. Those are the common things which we see in people with gender, the LGBTQ community.
So, what is gender dysphoria and how is it treated?
Like we talk about gender dysphoria, or we call it as gender identity disorder. Now,
Okay.
suppose I am born as I have a penis, I have two testicles. So the sex assigned at birth to me is a male. You understand?
Yeah.
I don't feel like a male. I don't feel like dressing as a male. I feel very uncomfortable playing football. I love playing with a doll. I love being dressed with a frock. I love my hair to be long. So the gender assigned to me at birth is a male, but what I am feeling inside is like a female. So there is a mismatch or unease between the biological sex or the sex with which I am born and my gender. Gender identity is what I am. I can identify myself.
Yes.
Sex is the sex I have been assigned it. So this is gender dysphoria. So there is a trans man. These are who have the biologically they are women, but they feel like a man. And we have trans women who biologically are male, but they identify themselves as a woman.
So is it treatable? Like, is that like parents should be worried? Sometimes parent, उनको पंडित के पास ले जाते हैं, स्पिरिचुअल प्लेसेस पे ले जाते हैं और कंसिडर बंद कर देते
शादी
हैं
करवा देते हैं,
डॉक्टर।
बहुत चीजें करवाते हैं कि ठीक हो जाएगा, पर ऐसा नहीं होता है. Generally, we use the Dutch approach. Dutch approach is we'll allow them to grow. Once they, the major transition periods are when the person has puberty. Like in a female, it might be 11 to 12 years. In a male, it might be 13 to 14 years. That is the moment when a female might have the enlargement of the breast. There might be pubic hairs and all that. And that makes them feel very uncomfortable. For a male who has been assigned the sex that male has been, he or she he feels bad at that time. This is a moment they feel very, very, they are very uncomfortable with what they are doing. Some people improve from the age of 14 to 16, 17. So we generally don't intervene. Maybe after 18, 19, it takes them a while to accept. Then there's a struggle with the family, with themselves, and maybe they come to us at the age of 24, 25. So there are two ways we treat them. So there is hormonal. We start with hormonal. First of all, we need to assess whether they are actually, because sometimes what happens, there's a trend to feel like this, like this. We need to be 10,000% sure that they are what they are telling us. Because we intervene somewhere and that it becomes irreversible. Suppose somebody wants to be a woman and we cut off the penis and the testicles, that can never be regrown back. We
Right.
take away ovaries and uterus, they cannot be getting back. So we need to be doubly sure. So we start understanding from the very beginning how they were born, how they were identifying, how they were playing around, what were the play activities, what were their dressing activities, how they are living in society. Suppose I am born as a woman and I identify myself as a man. Am I living in society as a man? Have I cut my hair short? Am I wearing? Then we start giving them hormones. First, we give them reversible hormones. Suppose they feel distressed, we need to take it out. The hormones will make them feel more towards the gender they can identify. Then we understand whether they're comfortable. And then we go for surgery. Surgeries are of different types, from top surgery to bottom surgery. A lot of surgeries that are available. And we've done a lot of interventions and we have seen that people are I've never seen somebody coming and telling me that, why did you give me the hormone or why did you prescribe a surgery to me? Because I go slow. I'm very, very relaxed. I see that for the last 3, 4 years, 5 years, they've been staying in society. There's one person who wants to be a man but still keeps long hairs. I tell no, I'm not going to do that. As long, because once I do the surgery, you cannot have an operation then live as a woman. See, I have to be comfortable with the fact that what I am doing is the right thing. Just because you're pressing me or telling me to do things, I won't do it. So that is the procedure. It's a little long procedure, but I think that is required because it has to be definitive, because it is irreversible. And if the
What is your
interventions
one message to the parents who children show these symptoms and then they do weird things to their own children? उन्हें मारते पीटते हैं, उनको बंद कर देते हैं और उनको अलग अलग ट्रीटमेंट कराते हैं.
I mean, I'll tell you, the parents have been taught the binary thing. हम पेरेंट्स को गाली देने से नहीं चलेगा. I think somewhere the parents also don't want their children to be distressed. They're looking at society, they're looking at their child. Somewhere the societal pressure overtakes their love, care for the child. Many times people tell them that इनको ऐसे करने से ये हो जाएगा, ये fair. I think you need to go to a mental health professional. You need to assess it properly. You need to have empathy for your child. You need to, buy out time also sometimes. I tell them the Dutch approach is the best. Okay, live up to 18, focus on your studies. After 18, let us concentrate on whether you want to be a woman or a man, or you want to continue, you want to get. So at the age of 18, 19, you're out of the societal pressure also.
Yes.
Because if a small community, we are answerable to a lot of people, and the parents are not psychological that oriented to understand, to withstand the pressure of what the chacha is telling, what the mukhia is telling, what Sala is telling. That's tough. They live in a very, very. So we need to have empathy for the parents also. We cannot just tell that because I am feeling like this, everybody around has to be changed immediately. I also have to accommodate my parents' thought processes, their emotions, And once they come to us, we try to make one of the parents an ally of whatever is happening. Because when two parents come to me, I look at one of the parents, I see somewhere somebody's face, a little bit of care and empathy. I work on that parent. I tell them that I'm there. What is society? Society is us. And among the us, I'm an influential member of the society. If I am telling that it is not that bad, that wrong, it is normal to feel like that, and we can work on certain things. The moment we give them the support to one of the parents, we make them strong. We make them understand that it is not just about five people telling that it is wrong. There are a lot of other people also who talk the right things, who are there to take care of the whole transition, the change that is happening, and we make them feel that yes, we can work on this, and
Yeah,
you are not one isolated incident or a person. So there's a lot of people that those are going through this, and we are there for you. And I think sometimes,
definitely,
yeah,
definitely. Parents also need a lot of support because it's not
I
easy
always tell
for
that
the parents
they
to
are there, the people who have given
accept.
birth to you. How can they be your enemies? How can they think against your wishes? Their thought process is this much. It takes time for us to make them change.
Right, very true. बच्चों को भी उतना ही समझना है जितना पेरेंट्स को समझना है. It's a mutual effort
समझना
basically.
समझना है, समझेंगे तो कैसे होगा?
So one last question, and thank you so much for being so patient with me throughout the process. And I want to, this is very common question that I'm getting. Um, so grief of losing out a loved one. कभी कभी ऐसा होता है कि आप मिल भी नहीं पाते हैं, जैसे आप सबसे ज्यादा प्यार करते हैं, जैसे पार्टनर हो गया, या आपका कोई चाइल्ड हो गया. अगर आपका ऐसा कभी इंसिडेंट होता है, एंड दैट पर्सन हु इज लेफ्ट बिहाइंड, तो ही और शी फील्स लाइक डाइंग कि अब मेरा कुछ मकसद नहीं बचा है, आई शुड टेक अवे माई लाइफ. So how should we treat and help that person, a friend or a family member?
Nothing is permanent. The first thing we need to understand in life is nothing is permanent in our life. I always tell to people, either we go out of people's lives or people will go out of our lives. Nothing is permanent. But what is important is, even if somebody is there with us for 5 years, 10 years, 15 years, 20 years, we need to make the best of whatever it is. We need to have great moments. We need to be connected. We need to be happy with each other. We should not feel somebody's loss after somebody is gone. We should feel somebody's presence when somebody is there with us. It's very important. People will go, people live. Tell that our parents are the most precious things in our life. They've been there from the beginning, they'll be there till the end. And many of the people have lost their parents. They're surviving. Everybody survives. It's just that you feel the loss of a loved one. And I always tell that the loss will always be there. Nobody can take care of that loss. That doesn't mean that you cannot carry on with other aspects of your life. You cannot be happy, you cannot smile, you cannot dance, you cannot party. Why will you not do that? People think that if somebody is lost, he should be wearing disheveled clothes. He should be, the outward showing of grief is not something everybody does. Some people grieve in private.
Yes.
They go in the car, they wipe their tears, they think they put on two songs, they cry in the car, they wipe it off and they're smiling. Everybody has ways to be sad, to take out their emotions, and it's very also important that you take out your emotions. But then you need to understand that there are others also who are dependent on you, be it your parent, be it your child, be it your wife, be it some, the people who look up to you. We need to live for them. We have memories. If I've lost somebody, I always think that he or she has gone to work, they've gone on a holiday, they'll come back, because it is the physical thing which is absent.
Yes.
But if you look at the emotional thing, if you look at what somebody has taught you, somebody has told you, the conversations, the emotions, they're always intact. Why do you think it's just a thought? No. The moment I start thinking that somebody is not there with me, not there with if I think somebody is there with me, he's gone out, he'll come back. I'm not telling that you live in a false sense of the world. I don't tell that. But yes, the memories are there, the teachings are there. There are a lot of things which are alive.
Yeah.
Think with those memories, with those emotions, with those moments, we can continue living our life. And then with time and with a little bit of patience, some of the sadness, intensity of the sadness goes down. Initial moments you feel, I have felt that same thing, that it's better I die. There's the use of living anymore. But then you know that you have a lot of people, you have a daughter, you have parents, you have this, whom you need to, well, who want to see you. If one death leads to 100 deaths, nobody will be surviving. It will like a domino effect. So you need to take cognizance of the fact that yes, there will be loss, there will be death. Death is the most inevitable part of this world, and we need to understand that any moment we might lose anybody in our surroundings. That's the basic truth. So let's celebrate life. Let us be happy. Let us spread happiness around us. And when the sadness comes, we need to understand that is all part of life. We need to accept it. We need to work on it, and we need to outlive the grief and be happy. What we actually are grieving is that a lot of things people are dependent. Like somebody loses his husband, who is the only prime breadwinner of the house. Somebody loses his wife, and he has nobody else in his life. Those are the moments where somebody actually feels. Some people are very, very dependent. Some people are just two of them or three of them, and they lose somebody. So I tell that you need to be connected to more people. You have to have. You can't put all your emotions only on one individual. Then the
Right.
grief is much more, and the grief complication is much more. That doesn't mean that you need to have three partners in your life. I'm not talking about like that. I'm telling that now, if you are connected with your parents, you're connected with your friends, you're connected with your cousins, you're
Have a
connected with
social
your
circle.
partner. Yes, you have a good circle which will, just cushion the grief or the sadness around you. So that's very important.
Amazing.
Everybody has a different way of dealing with. Some people show that deep inside. Many people don't show their vulnerabilities. Many people don't show their grief. Many people are excessively, overpowering of emotions. So there are spectrums. There are ways. There is no right way of grief. There is no wrong way of grief. Everybody to himself. But the more connected you are, the less chances of you getting into a complicated grief and doing something which only the people who survive understand.
Right. So thank you so much, Dr. Amrit. I think I can go on and ask you a lot of questions throughout, like 2, 3 more hours, but we have to cut it down because I think I've exhausted you already asking so many questions.
Right.
And I really want to appreciate you and thank you for taking out time and being so patient and calm with the podcast and the entire process. And really, you are an amazing human being and making a lot of contributions to the well-being of people. Yeah. So, as a founder of Saar Holistic Wellness, I really appreciate all your contributions and efforts that you're making. Hello, parents. If you find our podcast relatable, educational, then do subscribe to our channel. In the comment box, write your parenting challenges. We'll try to address them one by one. And never forget to share it with amazing parents like you. Because remember, by learning together, we can raise kind, confident, and connected children for happy families and happy nations.